7 o'clock, and we're going to get started, and people will join us as we go along. This is being recorded. All right, so we're just going to jump right in here. So my name is Dr. Kerry Forstall. I'm the president-elect of Maryland ACEP, and our guest this evening is Gene Ransom. He is CEO of MedChi and one of the main people advocating for physicians throughout Maryland. So thank you so much for coming, Gene.
Thank you so much for having me. I really appreciate it. And I really appreciate the great partnership that MedChi has with Maryland ACEP. It's been a wonderful teamwork and a long history. In fact, for a long time, you guys were even in our building and everything, but we've worked so closely over the years, and I really appreciate that.
Thanks. So we're going to jump right in with your presentation. While people join us, if this is the next in a series of town halls that we're doing, we're going to be doing them quite a bit in the coming year. And we have a lot of topics to share, but if you have a topic that you would like us to present on, please just put it in the chat. I'll take it down and we will develop some programming. So with that said, Gene, please take it away.
Terrific. So first of all, I just want to thank you guys for having me tonight. Again, MedChi is the Maryland State Medical Society. I'm looking on the call and I see a lot of members, and I thank you for being members. I'm going to talk about AHEAD, and I'm gonna cut right to the chase and give you the final part of it. The state of Maryland has quietly signed amendments to the agreement to keep it in place, and I'm going to talk about what those amendments are and what they do. And I'll talk about that. But I'm going to start with a couple really important key facts. And I particularly wanted to start with these couple of issues just to lay some background for everybody to make sure everybody kind of had a rough idea of how we got where we are. But I also wanted to talk a little bit about, before I jumped into AHEAD, about another issue that's very much related to AHEAD and is going to affect AHEAD, and that's HR 1. So HR 1, for those of you who are not aware, was a federal bill that passed recently. Some people call it by another name. I won't use that name because I don't think there's anything beautiful about throwing people off Medicaid. MedChi actually worked with California Medical Society to get all the state medical societies to oppose it. And you might say, well, why did they do that? Well, the reason is the AMA was silent at the beginning, and we were very concerned this bill was going to be really bad. Unfortunately, and the AMA did come around in fairness. ACEP was very early in opposing it, actually, national. But we opposed this legislation. Unfortunately, it passed. And it passed, and this is really important to understand because it's going to really change what goes on in Maryland. HR 1 is going to result in a large amount of Maryland patients losing their Medicaid coverage. This is very important for AHEAD, and I'll explain as I go through AHEAD how it fits in, but I think it's important for us to know this. There are a couple major issues with regards to this. Now, immediately under HR 1, folks who have documentation challenges are coming off, and you in your emergency rooms are probably already seeing about 60,000 patients across the state of Maryland that are no longer able to access their insurance that they were able to access prior to this passing. So that means we're seeing more people, and that means more uncompensated care under AHEAD, under the total cost of care model. So that's an immediate change. The thing is, there are a lot of other cuts that are scheduled. Interestingly, they don't take effect until after November of 26. I wonder what's happening in November of 26. Anyway, so we're going to be having automatic re-enrollments, additional match funding cuts that are going to result in more people coming off of Medicaid. This is really important because uncompensated care is a major problem for the total cost of care agreement that we're currently in, and it's going to be a big problem under AHEAD that we're going to be starting on January 1. But it's an acute problem for emergency room doctors. And the reason is because of EMTALA, you have to see everyone. And you are either employed by or have a contract for a company that works in a hospital. The hospital at the facility fee level might be getting a little bit of money in their global budget for uncompensated care, but the pressure on those hospitals is going to be greater. Your uncompensated payments for your emergency room visits are going to go up in this new model as a result of these cuts. And that's something that has to be thought about and dealt with. So I just wanted to make sure that we knew about this pending problem and we're thinking about it before we talked about the new model and what's happening in Maryland. So MedChi has been super engaged with regards to what's going on with the hospitals and rate setting for the last 10 years, really. Back in the early 70s, not so much because doctors are excluded. Even the emergency room physician payments are excluded. You're on a volume system. All physicians are on a volume system. But Dr. Lowentritt, who was president of MedChi 2 years ago, created a series of groups under the Looking Ahead Committee because the whole plan from the federal government was to shift states who were in Medicare waivers like we were in into ahead. And we came up with clear talking points that a big cross section of physicians agreed to on things we wanted to see. Those positions that we took to try to improve the model for the hospitals fell under healthcare transformation, population health, and primary care. And the reason we picked those is because those were the major headings under ahead, and that was what we were going to lobby for. So one of the big positives of what we had done, because MedChi was prepared and was kind of working on the problems ahead of time, we had a clear kind of consensus among the House of Medicine on what we were going to ask for, which made it helpful for us working through things. Now, we were also having growing complaints from members and physicians about all the problems with the hospital rate setting model in Maryland. And this is Dr. Radising. You see her sitting there at an HSCRC meeting with Dr. Berger and some others talking about problems like wait times, other issues that the system was possibly creating or wasn't doing enough to adjust for. So, we've been very engaged in all that. So we were kind of preparing to have a discussion about the renewal of the waiver. Now, when I say the renewal of the waiver, you guys probably go, wait a second, what is he talking about, this waiver thing? Well, Maryland has had this unique waiver for quite some time. In fact, I'm going to take a step back and I'm going to slide us back 1977, which is the first year we actually went on this waiver. And essentially what this Medicare waiver did was it said that hospitals are going to be paid differently in Maryland from anywhere else. And these hospitals are going to be rate set. And the state of Maryland was given from the federal government for Medicare, and in fact, for all payers, rate setting authority. And from 1977 to the early 2000s, that rate setting authority essentially was kind of the way it worked. And then in 2014, in the mid 2000s, we started moving more towards global budgets. So we went from a situation where we were setting unit rates for everything. Then we were doing charges per case. Then we went to global budgets. And that's kind of the history of the system. Now, interestingly, there were lots of states that tried to do rate setting. But the problem was they could never figure it out and have it work within the confines of the system. And most states fell out. In fact, the last state that had any kind of rate setting was back in the 80s or 90s, and it was New Jersey, and it just didn't work and it went away. But prior to 2014, what essentially happened was the HSCRC, the Health Services Cost Review Commission, which has 7 members and is an independent commission appointed by the governor and confirmed by the Senate, would literally, for hospitals, set rates. Now, the thing about that was prior to 2014, from 1977 to 2014, whether it be charge per case, and that's what this is on the screen here, a charge per case example. Prior to that, it was unit per case. The hospitals were still on a volume system. Now, the volume system meant that they really had an incentive. And for those of us, and I'm looking on the call here, most of you are too young to remember this, but I've been with MedChi since 1996, so I remember this. It used to be you'd see hospitals who would advertise short ER wait times. They would have trumpets on billboards about going to a hospital and all kinds of advertisements. Prior to 2014, the more work they did, the more money they did. They were on a volume-based system. They were getting rate set, so they didn't have to negotiate contracts for the private payers or for the or for Medicare or Medicaid. That was all done by rate setting. The rates were set by the HSCRC, but they still got paid for the more they did, the more they made. So that was a nice alignment, right? Whether you were in private practice or were employed, physicians were getting paid the same way. The more work a physician did, the more they got paid. The more work the hospital did, the more they got paid. And you had really good alignment there. And that was the way the system worked. Now, we still had to manage, and we had measures we had to meet, and we would occasionally get in a little bit of trouble with CMS, but Maryland was very adept from the 70s up until even current day and kind of meeting these measures and working through it. And as a result of that, we were able to slowly build more and more and more money coming into Maryland from CMS. And that's part of the dirty secret as to why this thing has lasted so long. But we went into a situation where in the 2000s we started to change. So the way we changed was we first started in the late 90s, 2000s with some pilot programs around total patient revenue where we set global budgets in the rural areas. And then what happened was those global budgets were very different. The hospital was no longer paid on a volume-based model. They were paid on a population health model. And so over time, we slowly crept to a situation where eventually the HSCRC started paying hospitals totally on global budgets. So that really changes the whole economic dynamic. And that's really important to understand about the model. We had the benefit of the extra money we were getting because we built it up over time. And we were getting subsidies for Medicare and Medicaid. And those subsidies that were coming in, those extra dollars, were really helpful because they were paying for things that we needed, things like uncompensated care, graduate medical education. All that stuff was being run through the waivers and through the hospitals. The insurers were benefiting from this because they were getting subsidies. The complexity allowed Care First to get a lot of power. But again, we were kind of running all along with the volume. We switched to the global budgets and we have a big change. Now, a big change means a lot, right? Because suddenly now physicians haven't changed how they get paid. Physicians have to negotiate a contract. So if you're on this call and, I see that we have folks who are employed by hospitals and I see we have people who work for large companies and I see a mix, right? So if you work for an ER group and you have to negotiate your contract, if you work for a hospital, the hospital has to negotiate the contract for you and you're still on a volume basis. You're getting paid for every patient you see. But the hospital you work in now is not on a volume basis anymore. So now we've lost a little bit of alignment. And that's important to understand with regards to the change of the system. So, but the dirty secret is everybody loves the system if they're in politics, because according to different studies, the state of Maryland is bringing in an extra $2 to $3 billion in revenue from the federal government that gets to pay for stuff that other states don't benefit. As a result of that, and this program being in place for a long time, Governor Moore thought, you know what, this ahead thing, it's not scheduled to start until after the election that's coming up. And I'm talking about the election for the president we currently have. So he strategically and his people made a decision that we're going to get this negotiation rolling and we're going to speed it up. And frankly, that frustrated a lot of us, even at MedChi, where we wanted to have more time to input and tweak things and try to create more alignment between physicians in different ways. But, the more people said, we need to sign this, we need to sign it with the Biden administration and get it in place because we're afraid that we won't have it if we don't do that. So literally the week before the election in 2024, Governor Moore signs the ahead agreement with the Biden administration. A lot of details in the agreement were left to future negotiation. The savings targets were really beneficial. The program was very similar to the total cost of care program that we have today, and it extended it with actually more favorable savings targets and a lot of things staying very similar. So the agreement kind of moves forward. Then we had an election. So when the election occurred, there was a very big change in policy. And the new administration with Oz and Kennedy and Donald Trump and Abe Sutton, who runs CMMI, said, we don't like rate setting from a philosophical point of view. We want that to go away. We think global budgets should be controlled by the federal government, not the state program. Maryland should not have the ability to do care redesign anymore. And the federal government should have total control of the Medicare dollars. Maryland said, wait a second, we want states' rights. We want the state to have rate setting. We've had rate setting since 1977. The HSCRC has done a good job with it. We want control of global budgets. We want the CRP program, CRP or care redesign programs. I'm talking about things like the Maryland Primary Care Program, the Episode Quality Improvement Program, the CTIs, the Care Transition Programs. These are programs that are kind of Maryland built, Maryland specific, but they apply to Medicare. So they're Medicare programs. They wanted to see shared control with Maryland kind of managing and running the ship. So we had a real tension that occurred almost immediately in January when the new administration took office. and a discussion occurred. And there were a couple shots fired over the bow. In March of 25, CMS announced they were ending the total cost of care agreement. That was the agreement we were currently in, and we essentially were in the last year of it. Now, we knew it was going away, but it was a little bit of a shock that they just said we're getting rid of it, so you couldn't go back. And a negotiation kind of ensued. Now, the state actually did create a coordinating council. They created a technical advisory committee. They had lots of input from different people, and then went back and forth on term sheets. I was in the meetings. They had Kevin Sowers from Hopkins, Ken Samet from MedStar, Mohan Sutra from Maryland, Dr. Sunthra. They had Brian Pennick from Care First, and Melanie Griffith, who has the Hospital Association. And we would meet with the governor every 2 weeks and the health secretary, and we would go through things and figure out what to, how to address and deal with negotiations back and forth. And most of the negotiations occurred with the health secretary, the head of the HSCRC. So these discussions went back and forth with regards to amendments to the AHEAD agreement that had just been signed. Essentially, the Trump administration said, I know you have an agreement, but we're willing to fight you on it, or you can make some amendments that we can agree to. So one of the biggest things that MedChi wanted to do, we had our 3-page sheets that I showed you at the beginning. That's Dr. Lowentritt and I, multiple meetings with the CMMI folks and the federal folks on this. We really wanted to see if we could save some of the primary care stuff. And I'm not going to go into that in detail tonight on this because you guys are ER doctors and I know you probably are interested, but there were primary care targets. We really wanted to keep the Maryland primary care program. We had some minor success on saving it. The primary care targets did get saved. We really wanted to save the episode quality improvement program. I'll talk about that in a little more detail. That's very important to emergency room docs, and I'll explain why. But the Care Redesign Authority was really important to us because that is a place where there's alignment for physicians and hospitals, and that's positive. We also didn't want a situation where the whole system exploded. If the money came out and we went to straight fee for service, $2 billion would come out of the system, and that'd be a problem. But we did want to make sure that the money followed the patient. So we had a situation where physicians there would be funds available to pay for physician services, which more and more has become a problem under the current system. So we were very involved in the entire discussion. Let's talk about Care Redesign and EQIP. So EQIP, for those of you who don't know what this is, and I think we've talked about this before, this is one of the key care redesign programs that was allowed under total cost of care. The original proposal from the current administration was to eliminate EQIP and MDPCP and just make it go away. EQIP is essentially an advanced payment model that allows physicians to take upside-only risk around certain chronic conditions or bundles. Now, MedChi worked very closely with the HSCRC and CRISP to create this entire program and this opportunity. It's been in place now for 5 years, allowed under our Medicare waiver. We were able to keep it in the AHEAD agreement with the Biden agreement. And then in the negotiations, initially they said they want to eliminate it. We talked the CMMI folks into keeping it in perpetuity. Not only that, we've had really good discussions with CMMI. They might even allow other AHEAD states in the future to do EQIP as well. The reason this is really important is it aligns physicians with the system. They get the benefit of the risk that the hospitals are taking without them taking the risk at the physician level. It is an advanced payment model, which means if you're in it, it's a qualified payment program and you're excluded from MIPS. So that's very helpful. There's a whole lot of categories. There's 123 bundles and EQIP. I won't get into all 123. There are emergency room bundles, and some of your members, Dr. Pines and others, worked very hard to develop emergency-specific bundles. These bundles have allowed emergency room doctors to get the advanced payment bonus, avoid filing for MIPS, and they have a shot at shared savings. Now, what we have found, and these are all the bundles that were available last year, 2 years ago, I guess. We have a bigger list now for the following year. But what we have found with regards to the ER bundles, we aren't having a high level of success on savings. So we worked collaboratively with the ER physicians who were involved in developing it. And we're going to try to change the baseline this year to see if we can't get a better result. So that's a positive too. But the good news is EQIP was saved. It's in the agreement. That's going to stay. The bad news is Some of the other care redesign programs like CTIs and some of the other hospital-based ECIP were eliminated. Maryland primary care is good for 2 more years. Doesn't really affect anybody on this call, but in 2 years, there's a study to see if it'll continue. And on primary care, they're going to go to some federal primary care programs that maybe aren't as exciting or lucrative. So that's really what happened with regards to the primary care. I'm not going to belabor that because, again, this is really for emergency room doctors. With regards to the hospitals, I want to highlight some of the bigger changes to the hospital agreements. The hospitals essentially, the rate setting authority is going to stay with the state of Maryland for the next 2 years. So essentially for the next 2 years, for 26 and 27, Maryland will stay in a very similar system. That similar system will mean the HSCRC is going to set rates for the next 2 years. Adjustments will be the same for the next 2 years. The only really change the hospitals got, because CMS is going to take over the budget starting in 2028, is that they got language that says at the end of 27, if they're not comfortable with the methodology or they're not comfortable with the agreement, they can back out of the agreements. So that's a positive for them because it means they have 2 years of stability to see what's going on. The second thing is they can still move forward if the global budgets, when they go to CMMI are okay. That's a positive. Another thing the hospitals got in this negotiation with the change, and the big change being that CMMI and CMS is going to take over the hospital global budget starting in 28, is that they increased the amount of they decreased the amount that is covered by the total cost of care agreement. The initial amount was supposed to be 90%. That got reduced down to possibly 85%, or the ability to go to 85%. Getting that number down is helpful because it can allow for some alignment. Now, this creates a lot of uncertainty starting in 28 because, we now have a level of stability that we know for the next 2 years. We're going to have very similar, setup where HSCRC is going to do what it's going to do. But there's a lot of uncertainty of how CMMI in 2028, which, by the way, is also, I would point out, a presidential election year, is going to set global budgets for 40-some Maryland hospitals. The care redesign programs are going to look a lot more like the national programs, but we were able to save EQIP and save the ER EQIP care redesign program, the ER EQIP bundles. I have on here the head term sheet has not been signed, but the head term sheet has actually been signed and the amendment has been signed. So that has happened since then. In fact, the amendment was just signed several weeks ago. We've put together some resources on the MedChi website that I want to highlight. The Center for Value-Based Care has a bunch of information. We have an entire ahead button, information on some of the different care redesign programs and other value-based care contracting. Great resource if you want to dig in deeper or watch some videos. We have some great videos on the EQIP bundles for ER. We have a bunch of information and materials up on ahead as well in the Center for Value-Based Care. We also have a Center for Private Practice of Medicine and a Center for the Employed Physician if you need additional information. I'm going to stop now, and I'm sure I've said a lot, used a lot of acronyms, and I'm going to just take the rest of the time to answer any questions anyone has about the model, where we are, hypothetical questions, changes, and how it would affect you as emergency room physicians. So I will go ahead and open it up now for any questions anybody might have.
Okay, thank you. Excellent presentation, Gene. Appreciate that. That's terrific. All right, we'd like to have people write their questions in the chat. I will read them. If you have a similar question or you wanted to ask the same question, just upvote it. That way we can kind of all share the information. So while people are getting their questions into the chat bar, I'll lead off by actually asking, you started right at the top of it saying that we quietly signed a document, we quietly signed to something. Could you tell me what that is, or could you explain a little bit more on that?
So I'm referring to the amendments to the AHEAD agreement. So when Governor Moore signed the agreement in 24 going into AHEAD, which extended the waiver, which he did strategically, the Maryland administration said, you know what, I'm worried that Donald Trump is going to win. And he was right. I mean, he predicted the situation correctly. because he was very worried about negotiating with Donald Trump on our Medicare waiver and keeping it. So he essentially sped the negotiation up. And that agreement that was signed with the Biden administration was done with a lot of fanfare. CMS came down to Annapolis. They had a big event. I mean, Dr. Lowentritt and I were at the event. We watched them all sign it and celebrate everything. Then what happened was when Donald Trump got elected, literally that that next a couple of weeks later, and then his people started coming in. They said, "Wait a second," And then what literally just happened was the state of Maryland and the federal government, the Trump administration and the Moore administration, have really quietly. There wasn't a lot of fanfare. They've signed an amendment to that ahead agreement to do the things I went through as the key takeaways. They've signed the amendment that now, instead of Maryland continuing to have the authority with the HSCRC, the authority for rate setting for the hospitals is only for the next 2 years. And then that authority for Medicare moves to the federal government. The state will remain to have the authority for the commercial payers and everybody else. So we're going to this split system in 28. So that's the big amendment. That's the big change. The other change is that the amount covered under the total cost of care could possibly go down a little bit under the new agreement. And then the other big change is that we are keeping EQIP in perpetuity, which is a positive for physicians. So it really has changed essentially who controls the hospital global budgets. So that really means a lot, Dr. Forstel, because if the CMMI or CMS controls the global budgets, they're not going to have the types of adjustments or changes. It's going to be probably a much rougher mathematics system where when there's a market shift, the market will shift. And then when the market shifts, the money will shift. And right now, the HSCRC takes into consideration other factors. There's also a lot of uncertainty starting in 28 in the system as to how is CMMI and CMS, how are they going to deal with the extra payments for things like GME and uncompensated care and all those other issues. We also have a pretty large Medicaid subsidy that works through the waiver, through the Medicaid assessment. So there's a lot of uncertainty starting in 28. But the positive is that the extra money that comes in through the waiver is going to continue. So we're not going to have a situation where 6 to 7 hospitals close down. So that's a positive. We also have a situation now where we know for the next 2 years we're going to be in essentially the same system. So that's a positive as well. And I do want to also point out that, remember, all these looming changes, this sort of Damocles that is hanging over our head in 2028 is a little bit exacerbated by the Medicaid cuts, because that puts a lot of pressure on all of us. If I'm an emergency room doctor, I'm thinking, my partner, who I might be getting a subsidy for uncompensated care or for call or for coverage, is going to have more financial pressure on them. Are they going to be able to continue that? That's a concern I would have. I would have a concern that I'm going to be seeing more people who don't have insurance because Medicaid has cut who has insurance or who has access to insurance on one end. And then the pressure that's coming on the waiver might reduce some of the subsidies that we get through the current waiver to those Medicaid patients. And how is that going to work? Because as an emergency room doctor, you see a greater percentage of Medicaid patients than other physicians do. I think you all know that. So I think you have some really big issues that as a specialty, they're kind of unique to you, that you need to plan and think about.
Okay. And you said they signed that within a week. It's amazing how fast government can move when it wants to, right?
Well, right. I would say the signature happened rather quickly, but there was a negotiation that lasted 9 months between stakeholders and different people,
All right. We have, and Deborah, please forgive me if I mispronounce your name here. We have Deborah Revert. And she says, or she asks, I understand a quorum of hospitals needed to approve of the ahead model as negotiated for to move forward. Is this correct? Do we have a sense of how the hospitals are responding?
That is a great question, Dr. Revert. So let me say this. So the first thing I would point out that originally the hospitals were responding in a very unpleasant way. They were very, very concerned because originally the federal government was going to have every hospital sign a 15-year participation agreement. But what happened was they took a step back, made some changes to the participation agreement, And the participation agreement that the hospitals are signing, this is the agreement between the hospital and CMS to be in the AHEAD program, now has the hospital essentially have a 2-year agreement where they have the ability to leave after 2 years. So I think the hospitals are going to sign on to deal with the next 2 years and move forward. But I think your point is a really good one. I think this is a fundamental issue that we should be thinking about for 2028. Because if there's uncertainty or the way that they're going to do rates in 2028 disadvantages a certain number of hospitals, you might not have enough hospitals to move forward with AHEAD. And essentially, when you talk about the quorum, the way you should think about it is it's a percentage of care. I guess CMMI or CMS could change the rules in some way, or maybe there could be some kind of negotiation. But if you're not covering right now 90% of the hospital-based care under the Medicare waiver or the AHEAD agreement, and you're going to hear people talk about total cost of care agreement, which is a Medicare waiver. AHEAD is a Medicare waiver, so that gets used interchangeably, just not to confuse anybody. But if you fell under that percentage, then theoretically you could have a problem. So that's a really good point. And I think how the hospitals react really at the end of 27 when they have to make that next decision will be the next big point. I think the likelihood that we end up with 2 years similar to what we're doing today is pretty high. But again, and I look on this call and I see a lot of young people, we got to really be planning for what's happening and what's going to happen. And I think this AHEAD situation and what your partners, the hospitals, are going to do, and how we react to these Medicaid cuts kind of in concert are really big key risks that you have to consider. The key threats that you need to consider as you're strategically planning for emergency medicine going forward.
Very good. All right. And Deborah also wanted to say thank you for taking the time to share your insights. So next up, we have Dave Myers says, what impact will these changes have on long waits in the ER and the disposition of discharged patients? And Tim Chismar asks a related question. Do you anticipate ED boarding to worsen, stay the same, or change?
Okay, I'm probably going to get in trouble for this answer. But I'm going to give it anyway. So first of all, I would just point out the state just released another report on ET wait times. On the positive side, it did get a little bit better. On the negative side, I think we're still the worst, with only DC being worse than us. And obviously, ED wait times is a problem across the country. We're having ED wait time issues. A lot of that is because, and I've said this repeatedly, ER doctors don't get paid enough. The other staff that work in the ED don't get paid enough, and we have incredible workforce shortages. And of course, that's why we have the problem. It doesn't take a rocket scientist to figure that out. Now, one of the things that I would argue is that the rate setting system, and in this case, the rate setting system actually has put penalties and incentives on hospitals to try to improve ER wait times through the HSCRC. I would argue that when you have a rate setting entity and a government entity controlling prices and costs on a system, when you have a non-capitalistic system, it doesn't move as quickly. So the HSCRC had to deliberate, and they voted, and they passed something, and there were concerns, and this got done, and that got done. In a market where there's a total market, where you don't have the government determining what things get paid for and what don't, it happens more quickly. So there's adjustments quicker, and people make changes quicker. So I would argue that while we're on global budgets, the economic incentives are such that we're going to have these kind of problems. That is not a popular position or one that a lot of people say. That is my personal belief. I think we're going to continue to have these problems because we have an acute workforce problem. There's not enough emergency room doctors. Emergency room doctors are not paid enough, in my opinion, across the country, not just in Maryland. We're even lower in Maryland because Maryland payments to physicians, the last study I saw, we were 48, with only Alabama and Delaware being lower. A lot of that is from the insurance monopoly. So it's hard for you guys to find somebody to work in your groups or at your hospitals in these positions. So we have staffing shortages. Staffing shortages lead to boarding issues and wait time problems. And then the money that goes to the hospitals is capped through global budgets, and the rate setting system makes adjustments, but those adjustments can be slow. So I think we're going to continue to have these kind of issues. I think the adjustments to HSCRC are going to make marginal improvements, but we're going to keep having these issues until we pay our emergency room doctors more money. I just told you 2 or 3 reasons why you might be making less money. So I'm not optimistic, uh, to put it mildly. And I think it's something that we're going to be dealing with going forward.
Okay, and actually, that's a good jumping on point for Mike Bond's question. You may have addressed some of this, but I'm going to ask it anyway, and then flip back to Tim Chismar's second question. So Mike Bond asks, he's our current president, can we expect our salaries to be going up or go down with this uncompensated care? How can we stay whole in the state and not have to move to another state? And I'll remind Dr. Bond is the upcoming immediate past president. He's on house arrest for another 2 years in Maryland.
So actually, look, I will tell you, I've worked for MedChi for 29 years. In fact, I just hit 29 years in September. I was a lawyer for MedChi ahead of time, and I was an economics major in undergrad. I spent a lot of time on these medical economics, these health economics issues, and how we deal with them. I am really troubled. The physician payment issue is one that I lose sleep over because I think it's a fundamental problem. And actually, I say healthcare worker payment issue too, because I actually don't even leave out our nurse friends and our PAs because honestly, they're not paid well here either compared to some other places. So what we have done at MedChi is we actually have been attacking this in a couple of different ways. We're putting in legislation in Annapolis to try to put pressure on the insurance companies to try to do better. And in fact, this year we're going to be going after downcoding, credentialing, and other stuff. So that's one thing we're doing. The second thing we're doing, and this might be one of the more important things we're doing for the emergency room docs on this call, is last year we passed legislation that took effect this year that essentially banned non-compete clauses for most healthcare workers. The way that legislation worked, which took effect on July 1 of 25, it said that if you have a non-compete in your contract and you're a licensed healthcare practitioner or physician, you cannot have that if you make less than $350,000. If you make more than $350,000, that non-compete is restricted to 10 miles around your principal place of work for 1 year. Now, you might say, well, what does that have to do with this answer? Well, non-compete clauses keep salaries low, okay? Because you don't have the ability to compete. You don't have the ability to move around within the state. To the point that Dr. Forrestal just made, Dr. Bond could move to Texas and probably get a 35% increase in his salary today. He could just pick up the phone and go there, right? Or go some other state, right? He could get more money going to another place. So the issue is, though, if he suddenly doesn't have a non-compete or his non-compete is not enforceable, that means that he would have the ability to maybe go to another place, Maryland, and stay here and get more money in that way. So we thought that was another important thing to do. The third thing that we're hyper focused on is Medicaid rates, particularly, are set by the state of Maryland. MedChi spends a lot of time, energy, and resources trying to keep those Medicaid rates as high as possible. That is very important for emergency room doctors, given the percentage of Medicaid patients as you see. But this is an acute problem, and that's why we're kind of tackling it in different ways. One point I did want to drive home on that non-compete issue. If you have a contract that was signed prior to July 1 of 25, it's grandfathered in, so you need to sign a new agreement. So, but I do think that's something you can think about. So those are kind of the things we're doing to address that issue. So we've really got to figure this out, because I'm worried that the uncompensated care issue is an issue that really hasn't been talked about. I'm worried the uncompensated care is going to go up, and there's not really a mechanism to put more money into the global budgets for it. And I'm also worried that you're just going to see more and more people who lose access to insurance with the changes under HR 1.
Okay. To go back to Tim's second question, and you may have already addressed this, and if we did, we can move on, but I didn't want him to think that I was ignoring his question. What happens to the HSCRC stays to rate set for commercial payers? So the impact of HSCRC on commercial rate payers. I'm not sure if that wasn't already all addressed.
No, actually, that's a really good question. I think it's good to bring it up again, just to go through it one more time. So essentially, and remember, originally the Trump people said, we want to get rid of rate setting altogether and not have it at all. The state said, no, we want to keep it for everything. And so the amendment, the compromise position, was that Medicare is going to be the rate setting authority for Medicare is going to go away from the HSCRC. So that is going to go in 28, starting in 28, to the federal government. The HSCRC is going to keep rate setting authority for the commercial payers. And I think what might be underlying in that question is, well, wait a second, isn't one of the tricks to the waiver that the extra money that comes in through Medicare is used to subsidize things like the commercial payers? And will that go away? And how does that work? And how will the HSCRC work if it's going to be doing rate setting for commercial payers for hospitals and Medicaid, but it doesn't have authority over Medicare? And then the other issue that comes up with that, and the other reason it's a really good point and something to think about, is you now have a situation where the hospital has to understand the rate setting rules and regulations for Medicare with CMMI and CMS and the federal government, and they need to understand the commercial rules with the HSCRC here in Maryland. So you've added a level of regulatory complexity that is unthought of in any other place. So I think it's a really good point and another thing to think about. And yes, I think it is going to be very challenging to see how it's going to work.
Okay. So I have a suggestion from Mike Silverman here. He's one of our past presidents, or he's the immediate past president. And one of the things underlying this terrific presentation is just the amount of work that you and MedChi have done for us. So Mike Silverman says, do you want to pitch why everybody should join MedChi?
Well, look, MedChi is we're the physician organization for Maryland. We're your voice in Annapolis. We work on everything. We work on legislative items. If you're employed, we have a Center for the Employed Physician where we can help you with your model contract with salary survey data specific to Maryland to help you negotiate a better salary. If you're in a private practice setting, we have all kinds of tools to help you with your private practice. And the other thing I would say is that our Center for Value-Based Care can be incredibly valuable, particularly if any of you are not doing EQIP. You should really do it. It's a great way to avoid MIPS filing and to get possibly an advance payment bonus and a shared savings. And maybe next summer when open enrollment for EQIP happens, we can do an educational seminar with Olivia or some of the people from that team with this group as well. But I just think we are your organization. We're looking out for physicians. We're fighting for you. So thank you, Dr. Silverman, for the chance just to make the pitch. And I'm looking on the list of physicians on the call. And I know a lot of you are members, but anybody who isn't, please consider joining or asking your organization to join. And for those of you who work for hospitals, a lot of your hospitals allow you to use your CME funds and your education funds to cover the cost of the dues. So it's not a big deal. So please participate. And thanks for the opportunity to make the pitch.
All right. I don't see any other questions, and we don't have to fill the hour. So people have things to do. Gene, if there's anything you'd like to close out with?
No, I just think the biggest thing is that we're going to be doing more and more of these educational events. And as more information comes out, we'll share it with you. I would also just urge anybody who wants to learn more about AHEAD or any of the value-based care stuff can go to our Center for Value-Based Care on the MedChi website to learn more, or you can reach out directly to me. I'm happy to talk to anybody, or you can shoot me an email or send me a message. It's not a big deal. And I just want to thank you again for having me tonight. I really appreciate the opportunity.
All right. Thank you so much. And folks, anybody, if you have things, we're going to be doing these town halls on a quarterly or bi-monthly basis, depending on how we can get the programming together. So if you have things that you want to talk about, we'll be doing a legislative thing into the new year. But if there are topics that you want to talk about, please, by all means, let us know. We will get the best people we can, just like Gene here on this subject, and we will put something together. All right. And I guess that's it. Thank you all for coming.